This video is going to be about Medi-Cal and special education and how, the government kind of supplements the services for your child in the public school system. And if you don't know how it works, because all children have a right to learn at the same, have a right to access the same curriculum. And it has to be age appropriate. So when they're putting people so far below basic and then it's not age appropriate, our children are not making up that progress. And so we need to talk about that. And so here is a little video. I haven't watched it yet, but I'll watch it with you and intervene if should I think I need to. And so let's share the screen, shall we? Okay, push play.
Attendees are in listen-only mode.
Good morning, everybody. Thank you for joining us for today's webinar on an overview of Medi-Cal as it relates to children with special needs. And I'm Fit Marks, the Director for Family Voices of California, and will be hosting today's webinar. So before I introduce our wonderful speaker, Dr. Catherine Smith, I'd just like to tell you a little bit about Family Voices. Many of you, I'm sure, are very familiar with the work that we do, but for those of you who are not, just a key few points about what we do. So we're a statewide coalition of locally based parent-run centres working to ensure that children and youth with special healthcare needs receive quality healthcare. And as a state affiliate of the National Family Voices, we are California's federally funded family-to-family health information center, and we provide statewide support and resources to families of children with special needs. Our webinars serve as statewide trainings on various child health related topics and are geared towards diverse groups, families, professionals, parent-to-parent, resource staff, and advocates. If you have any technical difficulties, you can always call the GoToWebinar number that you see directly on your screen. And due to feedback issues, we have everybody on mute from our end. Throughout the webinar, please feel free to type in any questions that you might have in the question box down on the right-hand side of your menu. And we also have time for your questions at the Q&A at the end of Catherine's presentation. Today's presentation is being recorded and it will be posted on our Family Voices website tomorrow probably. And afterwards, after this webinar, you're going to be emailed a very short evaluation survey, and we really appreciate getting your feedback. So it is now my pleasure to introduce Dr. Catherine Smith. Catherine has over 35 years of experience caring for children with special healthcare needs and their families, including those with neurodevelopmental disabilities. Catherine is an associate professor of clinical pediatrics at the Keck School of Medicine at the University of Southern California. Also at Children's Hospital Los Angeles, she serves as the associate director for policy at the USC University Center of Excellence in Developmental Disabilities. Catherine is the co-director of the Spina Bifida Center and co-investigator of Autism Speaks at Children's Hospital LA. Catherine is also a nurse care manager and clinical manager in the Boone Theatre Clinic at Children's Hospital LA, and the co-director of the Rett Clinic at Children's Hospital LA. Policy concentration leader within the leadership education in the neurodevelopmental disabilities, the LEND training program at the UC EDD, and the nursing director for the leadership education and adolescent health training program at Children's Hospital LA. Catherine has a strong interest in child health policy, quality improvement, and research in all these areas. She has extensive experience caring for children with spina bifida and their families, and has led Children's Hospital of LA efforts in participation in the National Spina Bifida Longitudinal Patient Registry. She teaches the public health and nursing programs at UCLA and the public health program at USC. Wow. So thank you, Catherine, so much for your time today. You can take it away from here. I'll change the presenter role over to you.
Okay, thank you. Well, welcome everybody. That was a lovely introduction and possibly a little bit tedious and longer than it needed to be, but thank you, Chip. So Chip mentioned questions at the end, which I know you usually do with your webinars, but I think what we'll do is have you type in questions as we go along. Let me see. Let me follow the directions here to show my screen. Yep, where's my screen?
Yes. Oh, I changed it over to you. It should be, it says we're viewing your screen. If you just bring up your PowerPoint, have you got your,
Oh,
yeah, just bring up your PowerPoint and then we'll go to the first slide.
great, thank you. Okay, so technical expertise is not my thing. So policy might be, but not this. So from the beginning, there you go. So I think what I'll ask you to do is if you have questions, let's do the questions real time so that I can answer them right then and clarify things. And we will, Pip will forward those questions to me and I will answer them. So we'll go ahead and get started. So I assume that many of you actually know quite a bit about Medi-Cal and how it works. So for some of you, this is going to be old stuff, and hopefully there'll be some new information for others of you. We're going to talk about both Medicaid and Medi-Cal. It's important to understand how the Medicaid program works in order to understand what kinds of rules we have to live with in California in our Medi-Cal program. So Medicaid is the federal program and Medi-Cal is our program. And we'll go over that in more detail in just a moment. Let's see, where is my slides aren't moving.
If you can, Kathy, can you just click your arrow, your forward arrow on your
Yeah. Oh, there it goes. There it goes. Okay. Thank you. Okay. So the first thing I want to start out with is the Maternal and Child Health Bureau's core outcomes for children and youth with special healthcare needs. And I want to start out with this because these are the 6 things that MCHB, it tells us we need to be focusing on for kids with special healthcare needs. So families as partners at all levels, kids receiving coordinated ongoing comprehensive care in medical homes. I'll come back to the bolded one. Screening early and continuously for special healthcare needs. Services organized in ways that families can easily use them, and youth with special healthcare needs who receive transition services. And most importantly, in today's context, is that families have adequate private and or public insurance to pay for the services that they need. So you can see that making sure that families have adequate insurance is a priority for the Maternal and Child Health Bureau, in particular as it relates to kids with special health needs. And we know that Medi-Cal is a very important piece of that coverage for kids. So first of all, what is Medicaid? It's health insurance for low-income and disabled individuals, and we'll talk about eligibility in just a moment. It's part of Title 19 of the Social Security Act, and it was established in 1965. So quick, who was the president then? Okay, it was Lyndon Johnson who promoted the notion of Medicaid. It's administered by the Centers for Medicare and Medicaid Services. And expansion of the Medicaid program was really a principal focus of the Affordable Care Act. And states expanded their Medicaid program to serve additional populations. And California really took up the cause and did a massive expansion. Unfortunately, a 2014 court ruling said that the states did not have to participate in the expansion. And so some states have chosen not to and have gone back to their pre-Affordable Care Act services. So Medicaid is an interesting federal and state partnership. So the federal government plays a role in Medicaid services, and then the states play a role as well. The feds define the scope of services, the extent of coverage, and certain administrative requirements. And the federal government also provides matching funds to the states to provide services. Generally speaking, across the country, it's about a 50-50 match. So for every 50 cents a state spends on their Medicaid program, the feds match that with 50 cents. It varies a little bit by state, but that's sort of a round figure. So you can see why it's important to a state budget that anything they spend on their own Medicaid program is likely going to be matched by the federal government. So it's a good source of revenue to help the state provide care to people who are low income. The states are responsible for administering their own programs, determining income eligibility within federal guidelines, specify exactly what services are covered, and the payment level and method. So we'll get to some specifics when we talk about California, but there are certain federal rules that the states have to abide by. And beyond that, they're able to determine some of their own guidelines. So for instance, in California, as probably most of you know, we have recently chosen to cover undocumented kids. That is not a federal requirement. Likewise, we have expanded Medicaid to serve individuals who are beyond, who make more than the federal requirement. So our Medicaid program is particularly generous in the way we have interpreted the rule. We also determine our own payment levels and how we do that, and we'll talk about that in a moment. But we do provide most of our Medi-Cal services using managed care. States are not actually required to participate in the Medicaid program. And, but as of 1982, all states have agreed to participate. Okay, shout it out if you know which state was the last one to join Medicaid. I'll give you a second. What is Arizona? Yes, that's right. Arizona was the last state to join the Medicaid program in 1982. So some numbers about Medicaid. It's a tremendously important program for providing care to Americans. 75 million low-income Americans were covered by Medicaid in 2017. 37 states have adopted Medicaid expansion to serve more than the minimum required by the federal government. Children account for 43% of all Medicaid enrollees, so it's very much a child-serving program. Elderly and people with disabilities account for 25% of the enrollees. The remaining, you can see that that number doesn't come up to 100%. The remaining are low-income adults. It covers more than half of all births in the United States. So a tremendous source of support for prenatal care and delivery. Covers 48% of children with special health care needs. Now, I want to stop there for a moment because when we take care of kids with special health needs, especially for those of us who work in children's hospitals, we tend to think of Medi-Cal being the primary payer of kids with special needs, and certainly it is. 48% of kids with special needs have Medi-Cal. And likewise, probably have CCS as well. But over half of kids are actually covered in commercial insurance. And that's good and that's bad. Commercial insurance tends to reimburse providers better, but commercial insurance tends not to have the stringent requirements for quality of care indicators that, for instance, our CCS program has for kids with special needs. So it's a bit of a mixed bag in terms of coverage by Medi-Cal CCS versus commercial insurance. 60% of nursing home residents are covered by Medicaid, and 2/3 of enrollees across the United States get their Medicaid through a managed care plan. Now, that's good and that's bad. If you have your coverage through a managed care plan, the plan, by way of its contract with the state, whatever state that is, has the responsibility to help you find providers for your child or for yourself. If you're not receiving Medicaid through a managed care plan, you're receiving a quote unquote fee for service, you can take your Medi-Cal card any place you like. It allows you more flexibility to see the providers that you'd like to see, but it can also be challenging to find providers who will provide services to somebody who has Medicaid. So on one hand, Medicaid managed care is more restrictive, but there are some guarantees associated with quality and with access. On the flip side, Medicaid that's fee for service, lots more flexibility, but a more challenging time finding providers who will accept Medicaid. So who's eligible for Medicaid? Generally speaking, poor children and parents. And actually, as part of the Affordable Care Act Medicaid expansion, it also included childless adults. So in the past, childless adults had not been eligible for Medicaid because it was linked to receiving welfare payments, quote unquote welfare payments. And generally speaking, welfare payments go to mothers and children because that's who's providing care to the kids, is their mom. So the fact that we're now able to cover childless adults means that a whole new population of people are able to access healthcare services that hadn't before. Certain aged, blind, and disabled populations are eligible for Medicaid. Those who have supplemental security income are automatically eligible for Medicaid. Low-income pregnant women. And as I said, as part of the ACA expansion, all U.S. citizens and qualified non-citizens with incomes up to 133% of the poverty line became eligible for Medicaid, including childless adults. So very important expansion. You can look through the literature and find numerous studies, too many to quote, that describe the benefits of Medicaid. But generally, the various studies demonstrate the following benefits. Reducing unpaid medical bills, preventing delinquencies, and improving credit scores, which of course you can understand. Bankruptcy associated with excessive medical bills has always been a problem. So Medicaid helps with that. It reduces the poverty rate, not care rate, reduces food insecurity, improves the long-term health of recipients, reduces mortality and disability, reduces infant and child mortality, increases treatment of substance abuse, and increases revenue to hospitals. So many, many benefits associated with the Medicaid program. There are some current policy issues that are in play. Some states, in particular, some of the southern states, and in fact some of the poorer southern states, are beginning to impose work requirements for Medicaid. That is, if you want to receive Medicaid, you have to demonstrate that you're looking for work or that you are employed. And there have been some court challenges to that requirement. Some have been successful, some haven't. But in the states in which work requirements have been imposed, it has resulted in a reduction in the number of people who are qualifying for their state's Medicaid program. And it hasn't necessarily resulted in increases in employment. So it's not turning out to have the effect that people were hoping that it would have. Another issue, current policy issue, is the rollback of expansion. with ACA, we saw expansion of Medicaid in the state. And since that time, we have begun to see rollback of that expansion. In California, we've been very fortunate in that our expansion has continued. And the other current policy issue, and sometimes you hear the current administration talking about it, is the potential for block grant funding in the future. So what does that mean? I told you already that Medicaid, that the federal government matches the state spending for Medicaid at around 50% of their spending. So the idea with block granting is that the feds wouldn't reimburse that way. Instead, they would determine an amount that each state would qualify for and make that amount available to the states, allowing the states to do whatever they needed to with that money. Now, the problem with that is that, number one, is it the correct amount that the states are allotted?
I wanted to pause here for a moment because, the only reason I would be sharing this information is, if you have a child with a disability, you have to understand that they still have a responsibility to provide those services, and how those services are paid for is critical to the maintenance of effort for your child. And so, the problem comes in when a child is not meeting those basic standards and you cannot measure the benefit. And so that's where the federal government comes in to help provide that level of support and to ensure that qualified service providers are involved in the process of ensuring that accessibility happens. After all, we're only talking about American citizens. We're only talking about we, the American people, expect that all children will have a basic opportunity to thrive in America and, share their gifts, because each child is so critical. Each child is so beautiful. When you have a newborn baby, it's just like, it's a miracle, because not all people can have children. But when you do have one, understand that certain situations where people don't have the skills to provide a level of support that would be best utilized for a child doesn't exist unless it takes people to build collaboratively, build together to ensure that all children are making progress. I'm going to start the video again.
Number two, what if there's a population influx and you need additional money? Number three, what if you have a recession, like the Great Recession that we had, where people became unemployed and were needing to apply for Medi-Cal because they had lost their health insurance? And number four, what if you have some kind of natural disaster like Hurricane Katrina, where large numbers of people become unemployed or need health care, and therefore you need to expand your Medicaid program in order to serve them? So there are a number of concerns about the potential for sending block grants to the states for Medicaid in the future. So keep an eye on that. And that's certainly a place where everyone can be an advocate and express their concern about that if that becomes an issue. So I encourage you to look for that in the future. So let's talk about what's in a name. So states call their Medicaid programs a variety of names. For instance, I gave you some examples. So Tennessee, it's called TennCare. Wisconsin, it's called Badger Care. I'm assuming Badger is the state animal of Wisconsin. And in California, we know it as Medi-Cal. So let me stop. Before we talk about Medi-Cal, let me ask if there are any questions related to Medicaid.
Kathy, there's one that's more about eligibility for Medicaid/Medi-Cal, but you're going to be talking about eligibility at length sooner, right?
I am. I'm going to talk about eligibility for, but any general questions about Medicaid?
Not seeing any. Oh.
Okay, great. Oh.
Also, Miranda is asking, so she's just clarification. So Medi-Cal is Medicaid. That's
Yes.
what we call it. Yes.
Medi-Cal is California's version of Medicaid. Now, if you're taking care of somebody who's come from a different state, let's say they're coming from Tennessee, might say to you, oh, when I was in Tennessee, my child had TennCare. What they're saying to you was that their child had the equivalent of Medi-Cal in Tennessee, but their Medi-Cal program was called TennCare. So, you know, if you're helping a family from another state, when they move to California, just be aware that their Medicaid program could have been called something different in the state that they're coming from. But what they would be looking for here would be Medi-Cal.
Thank you. That's all the questions.
Okay. All righty. So Medi-Cal. So Medi-Cal, California's Medicaid program. About a third of the population in California is covered by Medi-Cal. It's a huge program in California. And about 42% of California's children are covered by Medi-Cal. So an important source of health care for kids in California. In 2016, California spent $82 billion with a B dollars on the Medi-Cal program. So it's a huge portion of our budget. In the 2019-2020 budget, the governor estimates that the state will spend $98.5 billion to fund the Medi-Cal program. And that's of a budget of $209 billion total. So you can see what a big whopping sum of money Medi-Cal represents in our budget. So therefore, it makes it sort of a vulnerable program. You know, people wanting to look at ways to cut costs and to be more efficient in the care of patients receiving Medi-Cal. It's jointly administered by the Centers for Medicare and Medicaid Services, as I told you before, and the California Department of Health Care Services. And then each county welfare department is responsible for the local administration of the Medi-Cal program. So signing people up, determining eligibility, etc. So what are some of Medi-Cal's vulnerabilities? First of all, it's a large portion of the state budget. So it's vulnerable to potential cuts. So we always have to be aware of that possibility. And basically, there are only 3 ways to reduce Medi-Cal expenses. One is to decrease the number of people served. We have not done that. We have chosen, in fact, to increase the number of people served by the Medi-Cal expansion that was part of the Affordable Care Act, by covering undocumented kids with full scope Medi-Cal now. The other way to reduce expense is to reduce benefits. And that's been tried in the past. There have been peer.
Okay, I paused the video because you sure come out like a loud mouth. I'm gonna make some chili.
periods of time when, for instance, adult dental care wasn't covered, or there was a threat to non-emergency transportation. But generally speaking, benefits have not been reduced. Where we have made efforts to reduce Medi-Cal expenses is reducing reimbursement to providers, which, as we all know, is not a good idea if you want to keep high-quality providers in your network, and if you want to make access to that network reasonable for people. I'm sure many of you have children who receive Medi-Cal, and you know how hard it can be to get into a specialist who takes Medi-Cal, because there are not a lot of them, and so there are a lot of people in line to get into those specialists. So we have kind of put it on the back of the providers to bear any of the cost reductions associated with Medi-Cal. And it makes our provider network very, very fragile because of the low reimbursement rate that we provide. So California spending per patient on Medi-Cal, California spends about $4,000 per enrollee in its Medi-Cal program. Only Alabama, Nevada, and South Carolina spend less per enrollee. And none of those three spend substantially less. It's in the neighborhood of a couple $100. But all the other states spend more per enrollee than we do. So who's eligible for Medi-Cal? So low-income parents, caretaker relatives, and their child. So that was the notion of people who qualified for quote-unquote welfare would get both a welfare check and they would get medical insurance in the form of Medi-Cal. Now we've expanded to low-income adults as well, low-income seniors and persons with disabilities, former Healthy Families clients, and Healthy Families used to be a standalone program, and during Medi-Cal expansion, it was rolled into the Medi-Cal program. So it's essentially seamless for families, whether they're actually qualifying for Medi-Cal or Healthy Families based on their income. They're all receiving Medi-Cal, even though technically speaking, it's two different groups. Children and youth in foster care are eligible for Medi-Cal. Restricted scope Medi-Cal is available for undocumented individuals, and that's just adults now, because we have taken in California to providing full scope Medi-Cal to all children, including those who are undocumented. And then there's special consideration for teens without the consent of their parents to receive treatment for sexually transmitted infections, pregnancy, family planning, mental health, and drug and alcohol treatment. And generally places that serve a lot of teens, like our adolescent medicine program here, like Planned Parenthood, they know how to help teens apply for those special consideration services. So what does Medi-Cal provide? It provides healthcare benefits, including mental health, dental, and vision for children up to age 19 with a family income at or below 266% federal percent of the federal poverty level. In this family score there. So we have expanded our Medi-Cal program to actually serve a very large population of families. It's not just 100% of poverty. It's now up to 266% of poverty for kids. For adults, it's less than that. And it includes undocumented children to the age of 19 years. Now, there's been an effort to expand Medi-Cal eligibility to undocumented individuals up to the age of 26 to be on par with the way we manage commercial insurance. That has not happened yet. It's gotten some pushback. It might be a challenging climate for that to happen, especially with all the concerns about what's happening with immigration. So we'll have to wait and see what happens with that. So what kinds of services are provided? First of all, service delivery. 80% of recipients are in Medi-Cal managed care. And some are still in fee-for-service Medi-Cal, but that's becoming less and less. And like I said, one of the challenges is that if you're in Medi-Cal managed care, you are somewhat restricted in the kinds of services you can obtain. You have to go to your primary care provider. They have to provide authorization for specialty services. But Medi-Cal has contracts with each of the managed care plans to actually provide access to services for individuals. And that's not always the case when you have fee-for-service Medi-Cal. But you have lots more flexibility with fee-for-service Medi-Cal. You can take it wherever you'd like, and you don't need to ask a primary care provider's permission to go there. But in turn, you might have difficulty finding a primary care, or provider to take care of you. So these are the kinds of services that are provided. Inpatient, outpatient, and skilled nursing care, equipment and supplies, therapies like PT, OT, speech therapy, clinic and doctor visits, labs and x-rays, medicine, medical transportation. There are some optional services for adults like dentistry, like chiropractic, and those might be reduced during times of budgetary constraints. But there are not optional services for kids. The kids package remains pretty much intact. Before I go on to EPSDT, any questions about Medi-Cal so far?
Yeah, there's a couple of eligibility questions, Catherine.
Okay.
So, Jasmine is asking, if my income is higher than what's typically acceptable by Medi-Cal, but my 16-year-old son is disabled, would he qualify for Medi-Cal? It's not for the whole family, it's just for his son.
Well, first of all, if he's disabled and qualifies for SSI, then he would automatically receive Medi-Cal as part of the SSI. If he's a client of Regional Center helps families with something called institutional deeming, which we'll talk about in just a few moments.
Okay.
If neither of those things exist, it might be tough to get him to qualify for Medi-Cal on his own.
Okay. Thank you. And then another question regarding fee-for-service. How do they determine if you get fee-for-service or not? How do you know which one your child is on, if they're on fee-for-service?
Okay, good question. So back in the day, everybody got fee-for-service. That's just the way Medi-Cal services were delivered. You were sent a Medi-Cal card, and you could take it any place you wanted. As states tried to hold down the costs associated with Medicaid, and in our case, Medi-Cal, they turned to managed care plans to help rein in some of the costs. And California moved people into Medi-Cal managed care in waves. So the first wave was low-income women and children. The second wave was individuals with disability. And there are ways to apply for exemptions to Medi-Cal managed care. It's difficult to get the exemption, but it is possible. So if you have anybody who enrolls in Medi-Cal right now is not being offered fee-for-service Medi-Cal. Everybody who enrolls now enrolls in a managed care plan. if you wanted to make an appeal for fee-for-service Medi-Cal, let's say you lived in a remote county in which there weren't any Medi-Cal managed care providers. That might be a reason to make an appeal to remain in fee-for-service Medi-Cal. Let's say your child has been with a provider for years and years and does not participate in any Medi-Cal managed care plans, but takes fee-for-service Medi-Cal and move into a different program. That might be a reason to apply for an exemption. But you can see by the number.
Oh, Kathy?
Or going into Medi-Cal. Mm-hmm.
Sorry, Kathy, we couldn't hear you. You were coming in and out, and it sounds like very important information.
Oh.
So yeah, you were just coming in and out. I don't know, but could you mind just that last part where you were saying, you know, where you're giving a situation with after you talked about a family being in a remote area.
Right. Okay. Or the child who has been with the same provider for a very, very long time. The provider takes fee-for-service Medi-Cal, but doesn't take Medi-Cal managed care, or doesn't participate in any managed care plan. And moving to a different provider would be a serious detriment to the child. That might be a reason to ask for an exemption. But you can see from the numbers, 80% of recipients are currently in Medi-Cal managed care. And any new recipients are automatically put into Medi-Cal managed care. So it's just the way we're moving toward. But if you've got a good reason, then you can apply for an exemption, but they're hard to come by.
Okay. Okay, and another question before we move on is Caitlin is asking if an adult under the age of 65 has assets more than 2,000 but has no income, are they still eligible for Medi-Cal?
There are some spend down rules, and some assets are considered and others are not considered. So that's a question that you'd have to ask your local welfare office, local program to assist with a determination.
Okay.
Not all assets are treated the same.
Yeah. Could you give some examples for medical transportation?
Sure. Medical transportation could be something like, you know, an ambulance in an urgent situation, but it could also be non-emergency medical transportation. So, you know, for instance, the child needs to be transported because they're in, you know, a very large wheelchair, or they're using a ventilator or something like that. So Medi-Cal can assist in paying for non-emergency transportation, non-emergency medical transportation as well.
Okay. There's several questions coming in, but why don't you move along, and then I'll field them out to you as they, you know, maybe towards the end, because I'm concerned about time. Can I just also ask, Catherine, would you be open, if we don't get through all the questions, would you be open to me emailing some of them to you, and you can
answer? Of course.
Okay,
sure.
Great. So then I can,
yeah.
I want people to think that, yeah.
I think we'll get through. Okay. We have time for questions. So, some of you may have heard about EPSDT, or the Early and Periodic Screening, Diagnosis, and Treatment Program. This is a piece of the Medicaid program, which was added in 1967. And the goal of EPSDT is to improve the health of low-income children by identifying a comprehensive set of benefits and services for kids. And also say that if something is identified during an EPSDT exam, that it becomes medically necessary treatment. If it was identified, any Medicaid beneficiary under the age of 21 years, even if it's not part of the state Medicaid plan. So let's say,
Do you understand the importance of what she just said about how if it's deemed medically necessary, then it could become a part of the child's services as long as they were under the age of 21. So I'll continue to play.
a child had a mental health condition that was identified as part of an EPSDT exam, and mental health treatment happened not to be part of the state plan, which is not the case in California. This is just a hypothetical. Because of EPSDT, the state would have to pay for that service anyway, because it was picked up during an EPSDT exam. So what EPSDT does is it provides a standard set of benefits and services to kids in Medi-Cal. So it provides more protection for kids than for adults in the Medi-Cal program. So why do you think that is? Shout it out wherever you are. Right. So the reason is because kids are more vulnerable. They're more amenable to early prevention in order to prevent later problems. They're developmentally vulnerable. They're vulnerable by their size and their age. So the idea of EBSDT was to put protections in place in the Medicaid program so that kids got a comprehensive set of benefits, especially well child checks, and got access to services when things were identified during an exam. And those services can be vision services, dental, hearing, mental health. So in California, EPSDT loosely translates to the Child Health and Disability Prevention Program. And CHDP delivers periodic health assessments to low-income kids, that's Medi-Cal recipients or kids who happen not to be in Medi-Cal but are under 200% of poverty. We basically don't have any of those kids anymore because all of those kids would be eligible for Medi-Cal now, including undocumented kids. But the idea is that the CHDP program makes sure that CHDP providers, who are mostly Medi-Cal providers, provide a certain package of preventative health assessments to all of the Medi-Cal kids that they are serving. So these assessments can be done by individual clinicians or managed care providers, health departments. Sometimes you'll drive around town and you'll see a sign that will say on the side of a clinic that will say free health exams for children. That clinic is using the CHDP program in order to provide those free health exams. If the child has Medi-Cal managed care, then those health exams are provided by the Medi-Cal managed care provider. But the benefit is that there are specific guidelines that have to be followed. Exams have to happen at certain intervals. Certain things have to be covered, like anticipatory guidance, health education. The exams can also be used for school, sports, or camp physicals. So that's a very good thing for if family is challenged with having the funding to get camp physical done or a sports physical. The CHDP program can pay for that. And I gave you the link for the periodicity schedule so that you can see how often those exams are supposed to be done. It very closely aligns with the American Academy of Pediatrics periodicity schedule. If you'll remember, exam at 2 months, 4 months, 6 months, etc. So there are a few less visits in the CHDP program, but by and large, it closely aligns. So Medicaid waivers, people always wonder, what is a Medicaid waiver. Raise your hand if you wondered what a Medicaid waiver is. That's what I thought. Quite a few people want to know what a Medicaid waiver is. So it sounds very complex and mystical, and it's really not. It's complex in the details, but the concept is not complex. So remember way at the beginning, I told you that the feds established certain rules for Medicaid that every state has to follow. Every state has to follow specific rules. So for instance, there's a rule, it's called the statewide-ness rule, that says that your Medicaid program basically has to be the same throughout your state. And that's because there's an effort to make sure that everybody in the state has access to Medicaid services. So what if you wanted to do a special pilot project, though, in San Bernardino County? We're going to focus on that county because it's a combination of rural and urban, and you want to see if you can improve access, et cetera. So you're going to do something innovative, and you're going to do it differently than the rest of the state's Medi-Cal program. Well, in order to do that, you have to ask the federal government to waive the statewide-ness rule so that you can test something in a particular area. So a waiver is merely asking the federal government, the Centers for Medicaid and Medicare, to waive a rule around Medicaid so that the state can provide Medicaid to an additional population, test something new and innovative. Oftentimes it's around testing something new. The research and demonstration waivers are very popular, and we have a number of them in California. And I just listed out some of the ones that we have. So we have an AIDS Medi-Cal waiver, home and community-based alternatives waiver, in-home operations waiver, palliative care, pediatric palliative care waiver, which actually doesn't exist anymore. It's just a way of asking the federal government to rule so that your state can do something innovative or different for a particular population. Now, one of the things that comes up often for kids who are served by regional center is Medicaid waiver institutional deeming. And institutional deeming is a process to obtain full scope Medi-Cal for developmentally disabled consumers under age 18, where the family income and resources are not taken into consideration. There? I assume so. Okay. Pip, can you tell me if you're still there? I had a little blip on my phone.
Yes, I'm still here.
Okay, good. Perfect. Thank you. So the consumer is assessed on his or her own merit. So this is where you will see, for instance, a family that appears to have resources or commercial insurance, also has a child who's receiving Medi-Cal. If the consumer has income and or resources of their own, for instance, they've got a trust fund, they may not be, this may result in them being ineligible. But the idea is to provide enough resource so that this child can be cared for at home as opposed to an institutional setting. So it gives the child access to all Medi-Cal services, including medical, dental, and the EPSDT supplemental services. So it's a great way for providing additional support so families can continue to care for kids who have significant needs in their own home. Some Medi-Cal policy issues that we need to think about. We always have to think about rate reductions to providers. And that's an area where you can be a strong advocate. If you hear of impending rate reductions, speak up to your legislators. Our Medi-Cal Our provider network is pretty fragile already. We don't need to make it more fragile or damage it further by having providers drop out. We will continue to see movement into Medi-Cal managed care. That's going to continue to be the wave of the future. Nothing's going to change that. And we have to be thinking about the possibility of block grants for Medi-Cal. That would be very damaging to California because, you know, we have needs that come up. We have the Great Recession. We have migrant populations. We have all kinds of folks who may need to be covered. And if the budget was constrained by a block grant, that would be challenging. One thing I didn't include, and I'll say briefly, is there are a couple of circumstances in which services are carved out of Medi-Cal managed care. There are two circumstances. First, CCS services. Families do not have to go to their primary care provider to receive authorization for CCS services unless they're in one of the whole child model counties. For those of us in the rest of the counties, CCS services are completely carved out of Medi-Cal managed care, and they essentially operate as two separate programs with communication between the two programs. The other set of services that's carved out of Medi-Cal managed care are mental health services for kids with serious mental disorders. Those services are provided through the county mental health programs, departments of mental health. And again, a person does not have to go to their primary care provider to receive authorization to go to a Department of Mental Health clinic to receive mental health services for a serious emotional disorder. And Pip, when I send you the slides back, I'll include a slide about both of those things. So we have a couple of minutes left. Are there any final questions? And I know, Pip, you said you have some.
Yes.
Oh, I should just say, there's my email in case you need me.
That's great, Catherine. Thank you. Yeah, there are several questions. So Jasana is asking, in California, if a child is served by the regional center, they're often turned away when it comes to behavioral mental health. What waiver can be used to get past and get past that and get services from both agencies?
That is a really good question. And honestly, it comes from lack of understanding of what kids need. That was a tremendous problem in Los Angeles County for a long time. And through discussions with the regional centers and with the Department of Mental Health, I should say parenthetically that here at Children's Hospital Los Angeles, we have a very large mental health contract with the Department of Mental Health. We see lots and lots of kids from regional center clients. And we've done a lot of educating the Department of Mental Health and the regional center both, that just because a kid has autism doesn't mean they can't also have depression, doesn't mean they can't also have anxiety or any number of other mental health disorders. What I tell families is, in one of my roles, I do a lot of triaging of calling into clinics for developmental and behavioral services. So I tell families to language of the agency that you're talking to. So, you know, if you're concerned about your child's behavior, maybe it could be autism, maybe it could be anxiety, maybe it could be a million things. It's obviously not your job to make the diagnosis. It's somebody else's job to do that. So I say to families, if you're concerned about autism, call the regional center, but focus on the red flags that you're concerned about that indicate autism, so that you're speaking their language. If you're concerned about behaviors that have more of a mental health component, use those words when you call the Department of Mental Health. So for instance, a family will say to me, my child has autism, but I think he has ADHD. He can't sit still. Teachers are having trouble with him. I'd like to consider medication for him. So what I say is when you call the mental health program, talk about those behaviors that you're seeing that lead you to be concerned about having the child having ADHD. Certainly, you can also say that your child has autism, but if you lead with autism, then the person on the other end sometimes at DMH will say, oh, let me stop you now, call the regional center. So that's not why you're calling them. So lead with what concerns you with whatever agency you're speaking with. So you're talking their language. And we've found that way we've been able to get kids to get mental health services, even though they might have a developmental disability. I mean, just because the kid has cerebral palsy or a seizure disorder or intellectual disability doesn't mean he can't also have ADHD or anxiety or anything else.
Yeah. Yeah, good.
Okay, I'm going to pause right there and just say how important that is to be able to speak the language of what your fears are about your child, because every child can learn. But we have to, as parents, be the engineer of that learning opportunity. And so, you know, there's really no reasons. So many parents don't even understand the power in what education will bring to a child. Simply, they don't understand the education system. And failure for African American children has just been accepted for whatever reason. We're talking about compulsory loss, but we're also talking about willful compliance. And that comes from slave mentality. We should be talking about ensuring that access happens and demonstration of the method of operation or what they're doing to ensure that children are really having access. And that's going to have to be a leadership role. And understand, stop looking for other people to lead you. Lead yourself to the real solutions that work for you, because everything is a public issue. Everything is out there in the public arena for you to find. I'm going to finish this up.
Thank you for that, Kathy. So another question, Rick is asking, my son currently has private insurance and Medi-Cal. He's 17 years old and a regional center client. Will his eligibility change when he turns 18?
No.
That is a good question. The regional center service coordinator should be able to help you with that. But when he turns 18, he should be considered independent and therefore eligible for Medi-Cal on his own. And I'm thinking perhaps he has SSI also, or maybe not. He doesn't qualify now with your income. But when he turns 18, he is, in theory, an adult, and therefore he can apply for SSI. Regardless of your income, he can apply for Medi-Cal, regardless of your income. But the regional center service coordinator should help you with that transition.
Okay. And Ursula is asking, what, if any, accommodations are provided for a child with disabilities and needs to be assessed or diagnosed, but the parents are Spanish speaking only?
Well, just what the condition is. Being in Los Angeles County, we have many families who speak other languages. So our regional centers, and we happen to have 7 in Los Angeles County, our regional centers have a lot of language capacity. Likewise, our mental health program has a lot of language capacity. But in this day and age, with people speaking so many different languages, it should be possible either through regional center, through the school district, or through the mental health program, depending upon where you're seeking services, to get adequate language assistance. And in fact, that is a requirement of the Medi-Cal program to provide appropriate services in the language that the family or child speaks.
Yeah, that's right. And Catherine, is developmental screening included in the comprehensive benefits?
Yes, developmental screening is a part of CHGP, it's a part of EPSDT. Developmental screening should be done for children when they go to those CHGP visits.
Okay. Let me just scroll through. There was one more actually, Caitlin was asking an interesting question, and do you know why was the first Medi-Cal managed care wave made up of vulnerable populations, like women, children, people with disabilities?
Well, if you think about it, everybody in Medi-Cal has some kind of vulnerability. So I think the thinking was starting with women and children who received Medi-Cal as part of a welfare package was that, generally speaking, those individuals were healthy. They were very low income and had vulnerabilities associated with being low income. But by and large, those were healthy people. And then the next wave of those individuals with disabilities, the idea was to hold down costs.
Right.
And ostensibly to provide care in a more coordinated manner, but probably mostly holding down costs by managing their care more directly.
Okay. Well, we're out of time. As I said, Catherine, there's still a few questions to be answered, so I'll email those to you and send your responses out to our attendees. But I just want to say thank you again for your fantastic presentation, and to all the attendees joining in today. So we will close the webinar, but I would love to see you, you're evaluating our webinar. So you'll get an email in about 5 minutes, and if you could give us your thoughts, that would be very helpful. So again, Catherine, thank you. Goodbye, everybody.
Of course, my pleasure.
Bye-bye.
Bye, everybody. Thank you.
Bye.
Hi, everyone. Welcome and thanks for joining us for our webinar on retrofitting the medical home.
Okay, start the share. That was some great information. Simply, not enough people understand how public services actually even operate. And it's going to be our personal responsibility to figure that out for our own children. So I'm bringing you information that I think that'll be beneficial, and I hope you take the time to listen to it, because all the way through the, recording the video, it shares vital information as to how the state gets reimbursed and why your child would actually even qualify for the services. So we're going to end the video.